Okay, I'm gonna let folks know, this is
Right.
Beverly from the Clark County Neighborhood Outreach Office. And I am recording this portion of this presentation, only the presentation. I'll also be notifying when after the questions when we're turning this back off again. But while the presentation is going, this will be being recorded, and the questions and answers will likely be recorded as well. And so if you have any aversions to being on the recording, please let us know and we'll make sure that you're omitted from this. I don't think I can actually like mask you. So you would have to take your video off if you don't want your face shown. Although I believe what we're going to be showing is only the slides. And so with that, I'm going to share the screen so that Dr. Melnick can take this over.
Actually, I think you might want to have me share my screen.
Okay, I will.
But allow me to share my screen and then I can run it, unless you want to run it and have me tell you to advance slides.
No, that would be awesome. So
I'm about to do that. I just, am I ready to go? Because
yes, you are ready to go, and
So,
we are recording.
just in terms of my position, so I'm both the public health director and the health officer for Clark County, but I also provide health officer services. So I'm the health officer for Skamania, Clots, Wahkiakum, Pacific, and Lewis counties, and I have a deputy health officer who helps with that. So I'm going to go ahead and share my screen. Give you the one that works here. There we go. Can you all see that?
Oh, yeah.
Yes, thank you.
Okay, so let me turn it into the slideshow mode. Still see that? Hopefully that's working. So I'm going to give you an update on COVID-19, and and thanks, Steve, for the opportunity. Thanks to all of you for the opportunity to share this with you. And I'm glad we're able to record this. So hopefully this will be useful for the other neighborhood associations in Clark County as well. So I'll start with the first slide. So actually, I've got some bad news to report, as well as some good news. Unfortunately, across the United States, case numbers are increasing. And we've had, in Washington State and Clark County, as well as in the US, we've had 3 waves. This is going back to last March. We had that first wave, and then a second wave, and then more recently, this third wave. And as you can see, when we have these waves of cases, there's a plateau afterwards and then an increase. And then this last wave that we had that stretched into February, we have this plateau here, but you can see that more recently the numbers are going up again. And in the United States, about a 8.1% increase in cases in the last week, an increase in hospitalizations, and beginning to see an increase in deaths as well. That wasn't the case at first, but we're beginning to see that. In Washington State, I'm going to talk about Clark County next, but in Washington State, the transmission is increasing statewide. So we use a term called the reproductive number. Reproductive number for a communicable disease is how many cases each case transmits to. So if one person infects one other person on average, that's a reproductive number of 1. If they infect 2 people, then it's a reproductive number of 2. Anything below 1, the outbreak or the pandemic is decreasing. Anything above 1 is kind of like compounded interest. The pandemic is increasing. So if one person infects on average 1.38 other people, then those each affect 1.38 other people. So you multiply 1.38 times 1.38 times 1.38, and you can see how over time you get an exponential increase. It's like getting 38% rate on interest, in the bank. So that becomes exponential. So after the plateau in late March, after that, following the holidays, that huge increase we had, the numbers began increasing again, and many counties across the state, including 4 of the 5 largest counties, see increasing numbers. The biggest number statewide are in younger people, younger adults, and teenagers. So we're seeing across the state sharp increases in people between the ages of 10 and 49, and shallower increases in children and adults 50 to 69. Hospitalizations, there's always a lag between the cases, and then as people over time get more sick, you see more hospitalization and then more deaths. Hospital admissions remain flat overall during the first 3 weeks of March, but now statewide they're beginning to increase. In Clark County, 1 month ago, we averaged about 42 cases per day. And in the last week, we've averaged 66 confirmed cases per day and 15 probable cases per day. The state was always counting these. I'll talk about the difference in a second. Yesterday, we had a total of 91 cases per day. So and I think there's another slide that discusses this, but I'll explain it now. The state has been using both confirmed and probable cases. Confirmed, there's 2 types of tests for COVID-19. One, and for the virus, by the way, is called the SARS-CoV-2 virus. That's the virus that causes the disease that we know as COVID-19. The confirmed cases are based on a positive PCR test. It's called polymerase chain reaction test, or PCR. It's a test for the RNA of the virus itself. And if you have a positive PCR, it's a confirmed case. The antigen test is a test for the protein, one of the proteins in the virus. And if you have a positive antigen test, it's termed a probable case. Epidemiologists and state health department have a different, probable, the word probable has lay connotations as well as connotations in public health and epidemiology. In terms of the probable cases, given the antigen test isn't quite as accurate as the PCR test, so a positive antigen is considered probable. That's a term we use. But we're testing mainly people who have been symptomatic or who have been exposed to active cases. And I give great reliability to these probable cases, and so does the state. We're treating them the same way. They are isolated, just like confirmed cases are, and their close contacts are quarantined. And I could get into more about the test metrics. It would take a little while. I'm happy to do that if you have questions, and to explain why I believe and we believe that these tests are reliable, even if they're called probable. Similar to the state, we're seeing increases in cases in Clark County, specifically among those that are 20 to 49 years of age. Our activity, we measure the activity of COVID-19 based on the number of cases per 100,000 population over 14 days. And in mid-January, it was at close to 474 cases per 100,000 in Clark County. That was at its height. At that point, we were seeing like over 200 cases per day. And then it decreased. We had that decrease after that wave. And then since mid-March, we've had gradual increases. And if you look at the last 14 days, actually we're hovering around 200 per 100,000. So it's going up. We generally measure these based on when I say this week, we usually count the 14 days up till 6 days ago. But if you look at the 14 days up until today, and again, the numbers can change because we're cleaning up the data, making sure that it's completely accurate. We're up to close to 200 per 100,000. Hospitalizations fortunately remain around 5%, but we're looking at that closely. And I believe, one of the things we're seeing is a bump post the Easter holiday and spring break as well. And we're going to talk a minute about why the cases are going up. So this is Clark County, and this is the same as the US map I showed you. Here's the wave we had. It looks pretty small compared to what our recent wave in March, last March. Then we had early summer. early to midsummer. And then we had this most recent wave, and you can see each time you reach a plateau afterwards, and then it starts going up again. And I'm concerned that's what's happening now. These bars are the cases per day, and this green line is the cumulative case count. And you've seen we've had over 20,000 cases in Clark County. How steep this curve is based on the number of cases per day. These are the number of confirmed cases and probable cases. Even if you leave the probable cases out, our case counts are very high. The active cases are people who are actually contagious at the current time. Your period of being contagious for COVID-19 is 2 days before the onset of symptoms, and then for 10 days afterwards. And as long as your fever has resolved for at least 24 hours without fever reducing medications and your symptoms are getting better, that's a contagious period. So currently we have 563 people that are in isolation because they are contagious. We've had 252 deaths. And like I said, the most recent rate for 100,000 is 147.6. But if we look at the even more recent data that we're still working on, it's higher than that. So one of the reasons we're beginning to see increases, besides activities that people are undertaking without masking or physically distancing, is the arrival of variants. So the name of the virus is, as I said earlier, is SARS-CoV-2. And every time a virus replicates, it makes a genetic duplicate of itself. So it basically makes viral RNA. Every time that happens, when this is occurring, we could call it a mistake, but the replication isn't exact, and you can get a genetic variation. You can get a mutant that arises, and some of these become established in the population, and that's what they are. That's what variants are called. They're basically, the virus has mutated and created a new version of itself. And some of these, I'm going to talk mainly about the variants of concern, because this may be helping to drive up the case numbers both in the US as well as in Clark County and Washington. And by the way, more than 90% of the cases in Washington now are due to variants. They're not the original virus. The variants of concern, specifically about variants of concern, those are variants that have been found to have certain properties, and one or more of these properties. And to give you an example of why they're concerning, some of them are more transmissible, easier to catch than the earlier version of the virus. Some of them are maybe create more severe symptoms and deaths. Some of them may be resistant to the vaccines that are used. Some of them may be more resistant to treatment. The variants of interest are those that don't have necessarily those properties, but we may have some beliefs that they're, in the lab, they may not respond as well to neutralizing antibodies, for example, from somebody who's been vaccinated, or they may not respond to treatment as well. I'm going to concentrate more on the variants of concern, particularly the 117 variant and the California variants, the 427 and the 429, because they're predominant in the state right now, and explain some of the concerns around those. We might talk a little bit about the UK variant and the California variants are both found in Clark County as well as in the state of Washington. So the UK, these are the most prevalent. The concern about, you may have heard about what happened in the United Kingdom where this variant arose. And by the way, this is another reason for us to remain vigilant and use physical distancing and masking, because the more virus that's out there in the community, not just in Clark County, not just in Washington, actually not just in the US, but around the world, we need to be doing this together, because the virus does not really give a hoot about geographic or national political borders. The more virus that's out there, the more likely we are to get these mutants and variants developing. The one that arose in the UK is significantly more transmissible than the original strain that we had here. And it may be more lethal as well. A recent study in 55,000 patients in the UK who are low risk, those infected with the B117 variant had a 60% increase in mortality compared to people who were infected with the previous strains. Good news about the 117 variant is that the vaccines currently available, including the J&J vaccine that's now on hold, are effective against this variant. The B1427 and the B429, the California variants, there's evidence that they are slightly more contagious than previous strains, and that some of the COVID-19 antibody treatments like monoclonal antibodies and convalescent sera, for example, may be less effective against those strains. So we're looking at those closely. We're not testing everybody for variants. These are samples that we're doing. So right now, earlier this month, the California strains were responsible for about 50% of the cases, of all cases in the state. And the B117, the UK variant, was responsible for about 35%. I may say that on the next slide. Yeah, I do. And I'll get into that in a second. These are just the numbers we've detected by the sampling we're doing. And we're not sampling every case. And I'll explain to you how we find this stuff. But you can see that the numbers, even in the sampling we're doing, especially for the 117 variant, the numbers are increasing. And I'll talk to you about the limited sampling we're doing in a second and how we do that. So I already said more than 90% of SARS-CoV-2 infections in Washington state are now due to variants of concern. Earlier in the month, the B117 variant was about 35% of the cases, and the California variants were responsible for about 50% of all cases in Washington state. Since then, because the UK variant doubles much more quickly, reproduces much more quickly than the California variant, the 117 variant is already responsible for about 50% of the cases in the state of Washington. So again, this is a variant that is more transmissible, reproduces quickly, and may be more lethal, cause more severe reactions than the previous strains. Fortunately, it's protected for by the vaccine. So how do we do this sampling? I may not have here's just a graphic of it. So the red is the B117 variant. You can see how it's taking over time. The 427 and the 429 are the California variants. So before I get into vaccines, let me tell you how we determine all this and how we get these numbers. To identify a variant, you have to send the specimen in we send it to the Northwest Genomics Lab at the University of Washington. They actually they look at the sequencing, the viral genome. And we do this, so there's we're testing about 10% of the samples in the state right now. 5% of the samples are done randomly, random selection of samples to see what the prevalence of that variant is. What percent of the cases are due to that variant. That's where we get the 50% and the 90% and the 35% from. We're also sequencing specimens for unusual situations because we want to identify new variants that might arise that may be more lethal or more transmissible. So if we have a case with an unusual clinical presentation, maybe let's say a very young person with serious complications, that would be a situation where we'd want to send it to the lab for sequencing so we can identify potentially a new variant that might be more lethal. If we have an outbreak with a large attack rate, let's say we have one of those super spreader events, we're going to want to test those folks because we're going to want to identify whether we have a new, more transmissible variant that's causing that. If we have an outbreak or a school and a hospital, we're going to want to do genomic testing, and we call it a phylogenetic analysis, to see which cases are related to each other and what the sequencing of acquiring the infection might have been, so that we can identify areas where we can do better infection control. If we have, and I may talk about this in a minute, if I don't have it on the slides, we can talk about it during questions and answers. If we have somebody who's recovered from COVID-19 and it's more than 3 months afterwards, they get a new infection, we may test their specimens for variants because we want to see if we've got a new variant that can cause problems in people who've previously been infected. And if we have a case of vaccine breakthrough, and I may talk about more about this in a minute, vaccine breakthrough is a new infection of COVID-19 in somebody who's fully vaccinated. So if we have somebody whose definition of fully vaccinated is 14 days after the second dose of the Pfizer or Moderna series, or 14 days after the Johnson & Johnson vaccine, if we have a new infection in somebody like that, we're going to want to test that for variants to see if we can identify some new variant that might not be protected as well by the vaccine. So we're looking at those, and I don't have a whole lot of data on that. Where the numbers are really small, but we're gathering data on that. So let me talk about the vaccines really briefly here. Some good news is that eligibility is open up to everybody 16 years of age and older is now eligible to get vaccinated. And we're recommending everyone get vaccinated as soon as the vaccine is available. And we really do need, we're a long way from herd immunity, but the more people get vaccinated, the less transmission we'd have. And I would speculate that if we hadn't had the percentage of population we have vaccinated now, this fourth wave would already be worse than it is. But I'm concerned about this fourth wave, and the governor did a press conference today and is concerned about it as well. If you're receiving a 2-dose vaccine, you may have heard that somebody a while ago, an expert said, we need to get the vaccine out as quickly as possible. It might be better to give everybody 1 dose and get everybody vaccinated and then come back and do the second dose later. Not a good idea. So number one is the vaccines are not as effective if you only receive 1 dose. The other problem is the longer you wait, the less likely it is for people to come back for the second dose. But my biggest concern is around variants. Some of these variants may have a partial immunity to the vaccine. So if you only get 1 dose of the vaccine, you may have some protection, but you have a much less robust response to the virus. And if you get infected with one of these partially resistant variants, what could happen is the variant will survive. And by only giving people 1 dose of the vaccine instead of 2 and knocking it out, we can actually end up selecting for resistant variants. So people really should get their second dose, and we need to get that message out there. You should receive it as close to the recommended interval as possible, but it can be given later if necessary. And the Johnson & Johnson vaccine, which I'll talk about in a minute, is on hold now. But the good thing about that one is it only requires 1 dose. They're all effective vaccines. All 3 of them are effective at preventing symptomatic infection. The Pfizer, Moderna, a little bit better around symptomatic infection. But the point I want to make is that all of them, including the Johnson & Johnson vaccine, are incredibly effective at preventing serious illness and death from COVID-19. We have a lot to learn about the vaccine. Somebody is asking, are we going to need a booster dose? We might. We know that the vaccine is more effective than natural disease in terms of immunity and strength of immunity and duration of immunity, but we still don't know for sure how long protection lasts. And there may be, I'd have to speculate about this, about the need for a booster. We don't know for sure how well they prevent people from spreading COVID-19 because early data show that they do have some effect in people with no symptoms, but there are some asymptomatic folks who are vaccine breakthrough. The vaccine breakthroughs are a fraction of a percent. They're really small. I think I looked at it recently. It's like 0.01%. But we don't know for sure how effective the vaccine is in completely preventing transmission. And we don't know, we're still learning, what we really need to have in place before we reach, herd immunity and everybody is protected by the number of folks who have received the vaccine. It's going to be probably at least 70 to 80% of people being vaccinated, including children. But again, we don't know how long protection lasts. The variants add some questions in there. And, one of the things I'm going to say at the end of this presentation is the concern that not enough people are getting vaccinated, and demand, as the supply increases, demand unfortunately is dropping. I want to mention briefly about the Johnson & Johnson vaccine because that's been in the news. And I want to mention about this vaccine because I think what's happened with this vaccine is a tribute to the work that's being done nationally around ensuring vaccine safety. On April 13, the FDA and the CDC recommended a pause on administering the Johnson & Johnson vaccine due to 6 cases of rare and severe blood clots in combination with low levels of blood platelets in people who had received the Johnson & Johnson vaccine. And the state paused it, and Clark County paused the use of the vaccine. Now, there are these 6 cases of blood clots after 6.8 million doses of the Johnson & Johnson vaccine being administered. So less than 1 in a million. Number one, I want to make that point across. I don't know of any cases in Washington State, and you can see the amount of J&J vaccine that's been administered in Washington. The cases were in women ages 18 to 48. We don't know whether the vaccine caused this reaction. And by the way, I'd also point out that one of the complications from COVID-19 is blood clots. Before I get to that, let's see. The other point I want to make, and it's probably on these subsequent slides as well, but the way this is found, this is where I want to talk about the safety of the distribution system. So you may have seen some of this on our social media site as well, but many of you have probably heard of VAERS, VAERS, and VAERS is the term for Vaccine Adverse Events Reporting System. That's what the acronym stands for. And basically, we have a surveillance system in the United States where virtually anything that happens after a vaccine is administered gets entered into VAERS. So if you fall off a ladder a day or two, a few days after receiving the vaccine, you may very well be entered into VAERS. A vaccine administration error, somebody gets the Moderna vaccine for their second dose. If they had received Pfizer for the first dose, they're supposed to receive Pfizer for the second dose and receive Moderna instead. That gets into VAERS. So vaccine administration errors, any untoward event, has nothing to do with cause and effect, gets into VAERS. And by the way, there's an app that the CDC has, I think it's called vSafe, that if you get the vaccine and you have side effects, you can enter into there. And I believe that gets into VAERS. But the point I'm trying to make is that this surveillance system, this national reporting system is mined continuously. And if an unusual pattern is identified, like these 6 blood clots, talk about looking for a needle in a haystack, that's identified really quickly. And out of an abundance of caution, even though it's 1 in a million or less than 1 in a million, and even though we're not sure about cause and effect here, there was a pause put on the vaccine use. And I'm making this point to state that our vaccine distribution system is very safe. And I want people to be confident that when they get a vaccine, there is a commitment at all levels to ensuring vaccine safety. And the vaccines we have are very safe and effective. And I mentioned here, it's a top priority. We're taking this seriously. And they're reviewing the process. And I believe the Advisory Committee on Immunization Practices and CDC are reviewing this, are going to have an announcement, I think, this week or the end of this week. And I just want to point out that we have a robust safety monitoring system in the United States. By the way, these cases occurred 6 to 13 days after the vaccination. We've been getting out messages to people who've received the Johnson & Johnson vaccine. blood clots can cause these kinds of symptoms. We're also putting it in context for people that this is a very rare event. And we've gotten information out to the providers because the treatment for these blood clots is different than treatment for other kinds of blood clots. And I can talk about that too if you want to hear some of that detail, but we've got that message out to providers. The other good news I have to say is that vaccine allocation in Clark County was, and Steve, if I'm going on too long, give me a signal and I'll be happy to stop. I don't know how much, I'm not monitoring the time really well, but I'm near the end. Early on in the process here, the vaccine allocation to Clark County and Southwest Washington was inadequate and inequitable compared to similar to other counties in the state. A lot of people, our Board of Health, our County Council, our legislative delegation, Congresswoman Herrera Butler, we all complained about this, and the allocation for the last several weeks, the last 8 weeks has increased more than threefold. And we're getting a larger portion of our population vaccinated. In addition, and that's the state allocation, we're also getting a lot of federal allocation that's going directly to pharmacies. In fact, the federal allocation of about 10,000 plus doses a week is more than we're getting from the state. And we're using that at our Tower Mall mass vaccination site that's still operating. So as of Monday of this week, we'd given about 250,000 doses in Clark County. And as you can see, nearly a third of the population, of the adult population, has received at least one dose, and more than a fifth are fully vaccinated. And our colors used to be lighter than a lot of other counties in the state, but you can see now that we're doing better compared to where we were 8 weeks ago. And I also want to mention the positives about being vaccinated, because we really do need to do a lot of work about convincing people. There's a lot of, and dealing with the mistrust people have. There's some good reasons besides not dying and getting severe complication. There's other good reasons for being, I mean, not dying from COVID-19 would be enough for me, but here's some other good news. 2 weeks after, when you're fully vaccinated, I've already mentioned when you're fully vaccinated, those who are fully vaccinated can gather indoors with other fully vaccinated people without wearing a mask. So, and you can also get together with unvaccinated people from one other household without masks, unless there's one or more people who live in that household who has an increased risk of severe illness from COVID-19. So now, if grandma and grandpa are fully vaccinated, they can visit their children and grandchildren in one household without masking, as long as there's none of the other people in the household is at risk for severe complications. That's good news. Those are full, and the other good news about this is that those who are fully vaccinated and have been in close contact with somebody with COVID-19 don't have to quarantine for 14 days or get tested unless they develop symptoms. And there's an exception to that, but the exceptions are people who live in a congregate setting, like in a jail or prison or in a shelter, or people who are residents in long-term care facilities or inpatients in the hospital. But the rest of us who are fully vaccinated and have a close contact, we don't have to quarantine anymore. Excuse me, we continue to work. Of course, if we develop symptoms, then we would need to be isolated and tested. However, in many situations, we still all need to take preventive measures when in public, when gathering with unvaccinated people from more than one other household, and when visiting somebody who's at increased risk of severe illness. And we also, and in those situations, we need to continue to practice the recommendations still are in public to wear masks and physically distant. Now, as more of the population gets vaccinated, and we hope we get to higher levels and we reduce transmission, I suspect we'll be relaxing some of these requirements, but we're not quite there yet in the current scenario. We should still, fully vaccinated people should also continue to avoid medium and large gatherings, follow the workplace guidance, and get tested if they develop symptoms. Okay, that was it. I guess I was near the end. So I'm all ready for questions, and I'll stop sharing so we can all see each other a lot better. And I don't know if I don't think I put anybody completely to sleep yet. So nothing in the chat. Steve, if you're talking, you're muted.
I was just going to ask Dr. Melnick if there has been good response so far for once it opened up a couple of days ago. I wondered if there's been a big rush.
No, you mean once it opened up to 16 and everybody's 16 years of age?
Yeah.
I wish there were a bigger rush. We're still
Really?
monitoring that, but appointments are available. Yeah, that's what's concern. So I'm glad you raised that question, because one of the things that's concerning to me moving forward is willingness to get the vaccine. And there's a lot of terms used for it. I've heard the term vaccine hesitancy, that's used a lot.
Yeah.
I was on a webinar with the Hastings Center. It was really interesting, and what they were basically, and we had this, you might recall, during the measles outbreak in 2019, a distant memory now, but there's a lot of reasons for why different groups of people are not getting the vaccine, but a lot of it, or at least a substantial amount of it, is based on trust. Lack of trust for government, or the CDC, the FDA. The vaccine was, the whole definition of, the warp speed terminology that was used. There's a lot of mistrust. And actually, the SARS, coronaviruses have been around for a while. This is a new one, but work on the vaccine started a long time ago, before this new, SARS-CoV-2 came around. And the vaccines have gone through extensive testing on tens of thousands of people. But there's a lot of mistrust about how it was rolled out, the role of government, and some of it, I complain that some of it is nonsense and anti-science, but some of the folks who are mistrusting actually use experts. There are some experts out there that have credentials after their names. I mean, Wakefield is the perfect example of that, yet who harbor, like conspiracy theories about this. And they're paraded out as experts as well. So it is really difficult for, I think there's going to be a lot of challenges around trust. And I think one of the things we're doing in Clark County is and you guys may want to volunteer for this, is the I Got the Shot campaign. You might be seeing this on our Facebook page, but one of the things we've noticed in different populations who are, where there's concerns about trust, is if somebody who's part of that community gets vaccinated and the sky doesn't fall, which is not going to happen, and more people get vaccinated, that helps build trust. So I think it's going to take all of us, not people like me who are not necessarily trusted by some groups, to really get the word out about this, that we're all in this together.
Thank you.
There are some populations have good reason not to have trust based on the history, of how, Black populations who might be concerned, given the history of research in the United States, the Tuskegee study and all that. But, there was another speaker on that Hastings Center call who basically said a lot of the issues with some of the BIPOC populations, I agree with this, is not about trust, it's about access. So when you provide, you get rid of the barriers to access for example, Black populations, their vaccination rates approach that of white populations. So one of the things, there's a whole lot, COVID-19 has demonstrated, like other things, the impact of systemic racism on outcomes. And we're really trying to deal with some of the barriers to some of our BIPOC communities of getting vaccinated. And I can talk about that for a long time, but we need to do a better job of vaccinating our BIPOC populations, just like, and we need to do a better job of providing other health services to those populations. I can go on and on about that as well.
Okay, we have a couple of questions in the chat, so I'll read them one at a time.
Okay.
The first is from Mr. Brenner, who wants to know what you think the pandemic will look like 6 months from now.
I'm going to use my favorite word, and my favorite word is it depends. So on the good days, I'm thinking we're going to get a lot of vaccine out there. We're all going to practice the appropriate behaviors. The fourth wave is not going to be so big, and we're going to be able to hang in there. I'm pleading with people to hang in there for the next few months. You know, I see these pictures of people gathering. You know, I mean, and it scares the heck out of me. But on the best of days, I'm hoping that by the end of the summer, by late summer, we'll have more people vaccinated. Our numbers will be down, and we'll be able to start getting back to some semblance of normal. But the concern I have is this can go in the wrong direction fairly easily, and it depends on, you know, keeping the virus numbers down and inhibiting the development of variants that might be resistant. So, you know, if I had to go out on a limb on this, I'm probably more than 50-50 optimistic that 6 months from now we'll be getting back to more of a semblance of normal, whatever that might be. But I'm also thinking, and I'm sorry for going on so long, but this train of thought here, but we may need to be looking at, I think the Biden administration already talked about some incentives to get people vaccinated, like tax breaks for employers that give people time off to get the vaccine, maybe some other incentives to get people vaccinated, people who might not, you know, get over that barrier of trust. We may need to be looking at some regulations around this. For example, workplace regulations, and I'm just making this stuff up, that basically, and we've seen this for the flu in with hospitals, that if you haven't been vaccinated and the pandemic is still going on, you have to wear a mask, where people who are fully vaccinated don't. But if you're not, you know, we may need to be looking at some regulations that basically, some policies that encourage people who are on the fence to get vaccinated. So I don't know the answer to that. That's going to be a community discussion. It's not my decision to make, and I wouldn't make that decision alone.
Okay, we have several other questions now. Greg would like to know, with international travel curtailed, how have these variants from other countries so quickly become a problem?
Yeah.
Well,
I'm sorry, go ahead.
He has one other question in there. We were also surprised by the Ebola scare in Portland and Seattle. Who traveled to West Africa recently?
Yeah. So, boy, let me deal with the other thing. When I was talking about regulations, we may need to have some regulations around travel too, in terms of fully vaccinated people traveling. So, that could be up to the airlines. I don't know if if you're crossing state lines, it could be up to the feds. But the concern I have is these variants, all these diseases, including Ebola, are basically a plane ride, a train ride, a bus ride, or a car ride away. We saw that with measles. You might recall that when we had measles here, was a child who had traveled internationally, was unvaccinated, and brought it, and that was the first case we knew about. I don't know if that's where it started, but the bottom line is, that's what scares me about this. This is a global situation. So if you have countries where there's a lot of viral activity going on, that poses a risk for the rest of the world. So we may need to look at more travel restrictions. I don't know the answer to that. In terms of Ebola, I believe we had some folks in Washington State who are being monitored for Ebola, but I don't think, if I remember correctly, I think there were people coming from the countries. I don't think we had any high risk exposures in Washington State, but I can go back and get that information for folks.
Great. Debbie Townsend wanted to know, she says, a lot of the people who are most hesitant to get vaccinated are also the most upset about masks, distancing, and other restrictions. Is there messaging planned around the idea that the more people get vaccinated, the more things open up as a way to motivate people?
Great question. the thing that bothers me the most about all of this, and this is true of the measles thing, is the fact that these issues have become political. I mean, the virus doesn't care whether you're independent, Democrat, Republican, conservative, liberal, communist, fascist, or whatever. It really doesn't distinguish. But somehow the vaccine itself, vaccination has become political, masking has become political. And I think it comes down to that whole issue of trust. I think some of the messaging needs to be the same. It needs to come from all of us, and it needs to be. I think we need to build trust with around masking as well as getting the vaccine. Somehow the concept, and I guess this is difficult. Maybe it's a cultural issue. I don't know, but we are all interdependent to each other. We don't all live on islands, and whether it's using a mask or getting vaccinated, one of the reasons for getting vaccinated is not just to protect yourself. And boy, I said this a lot during the measles outbreak, but it's to protect everybody around you, your neighbors, your friends, your loved ones. I'm not sure how to get that message across. I just know that somebody in my position, given the trust issue of government or whatever it may be, this needs to be a community. This is where neighborhood associations come in, where the I Got the Shot campaign comes in, building trust and making this more of, we're all in this together. The more we can do that, I think the better off we'll be. I don't understand people, no shoes, no shirt, no service, and you don't get into a restaurant. And nobody's complaining about that, but somehow this little mask that you put on is something that, people are getting excited about in terms of, this whole idea of this is freedom. I think our term about freedom is let's get rid of the virus so we can all go back and not have to deal with masking and physical distancing. But, that's my bias. I'm not sure I'm answering that question very well.
No, I think it's largely that it's been politicized. Cheryl Berkey wanted to know how vaccinations are being handled with the homeless population.
Yeah, great question. So we've done a number of, and this is kind of difficult. We're trying to do as much as this as we can. We've done some mobile points of distribution where we know that it's difficult for people to get to vaccine locations. The fairgrounds is really far away. That's why one of the reasons we set up the site at the Tower Mall in central Vancouver. We've done some mobile pods. We've done where we actually deliver the vaccine. I know we did adult family homes. We did about 1,000 people in over 150 adult family homes in Clark County. We're particularly concerned about populations working at some of the food processing plants where we have a number of large BIPOC populations. You might recall that the largest outbreak last year was at the Firestone. One of the large outbreaks was at the Firestone Fruit Company, and largely a Latinx population there. So we've actually brought vaccine out to a number of food processing plants. We've provided vaccinations at the Housing Authority as well. And we're also working with partners, if we can, to possibly do like working with fire departments to be able to do some distribute vaccines at some of the sites where there are unhoused people. I got to be honest with you, it's probably easier to arrange for transport to a place like Tower Mall because these one-off small pods take a lot of effort and resources to do. But we're trying to reach these populations. I know we're going to be doing a pod in Fruit Valley this Saturday, and we're hoping it's close enough to. I know there's some population recovery cafe that needs to be vaccinated, and hopefully we'll be able to get some of those folks there. And we're also doing a pod in the Woodland area at Woodland because we want to reach some populations in the north part of the county, including potentially agricultural workers. So we're doing some of those, but it takes a lot of resources and to reach relatively small numbers of people. Long answer.
Actually, the next question is a little related. Is getting an appointment for a vaccine injection the only way in Clark County? I've heard reaching some segments of the population better served by walk-in centers. Are there any plans for that?
That's an outstanding question. And that's been one of the barriers to getting some of the BIPOC populations vaccinated. There's a number of barriers. One is the way the billing for the vaccine administration that we're trying to work on with the state. Yeah, we're looking at expanding our Tower Mall operation. So right now it's 4 days a week and it's been by appointments. We try to set some appointments up. We have a portal with some of our BIPOC partner organizations, LULAC, League of United Latin American Citizens, NAACP, and PICOWA, the Pacific Islanders Community Association, to be able to get folks from those, to have a portal for those folks to be actually get appointments at the Tower Mall. But we're actually looking at, right now it's open 4 days a week. I believe it's Monday, Tuesday, and Friday and Saturday. We're looking at opening it on evening hours as well as on weekends, on Sundays, and actually having some of them walk in so people don't have to make appointments ahead of time. So we're looking at expanding that, and we'll have some information on that soon. But yeah, actually one of the concerns we had, the billing piece was a problem because asking people for health insurance and other documentation is a barrier. But even this requirement from the state that you had to administer 95% of the vaccine within 7 days, that was an impediment for some of these populations because you had to make appointments really quickly. And many of them are working in jobs where they can't get time off of work and working with hours that are difficult. So we've actually asked the state to put a hold on that requirement as well. So there are a number of barriers that have prohibited BIPOC populations, for example, getting vaccinated, and the appointment and the hours of operation have been an issue. So we're looking at expanding the Tower Mall and eliminating those two barriers.
Okay, well, I want to thank you very much. I don't see any other questions in the chat. We'll just take a second for anybody else to just register a question if you have one. And if not, we'd like to thank Dr. Melnick very much for taking the time for the excellent presentation, and thank everybody for very stimulating questions.
Yeah, great questions. Thank you. Thanks again for the opportunity, and thanks for recording this as well. Okay, bye-bye.
Well, we have a hand raised here.
Okay.
From Darwin Engwer, and since you haven't put anything in the chat, why don't you unmute yourself?
No, I was clapping for a great presentation.
Okay.
Thank you very much.
That's even better.
Great questions too. Thank you. Good night, everybody.
Thanks again. Okay.